Welcome to All Things Chiropractic.
Well, welcome to another episode of All Things Chiropractic. I'm Paul Andrews.
Welcome, everybody. I'm Dr. Mark Davini.
So, should we or should we not be doing and or charging for our re-exams?
Right, and that's the topic of today, managing your expectations.
Dun, dun, dun. So, first, let's just talk about re-exams themselves. Now, you're the doctor. I'm not. Does a doctor really need to do re-exams?
Oh, I am so glad you asked that question. Oh, my God.
What a waste of time, right?
Yeah, so let's put this to bed right now. Please, docs. I know you're chiropractors. I know we adjust subluxations of the spine. I know we expect the body to heal itself. I know all this, and I know it very well. But let's be clear. You have to, you must, you should do examinations. What's the reason for an examination? Everybody keeps, it tells me all this stuff I don't want to know. Exactly. It's all the stuff that tells you that they should be there. In one of our other podcasts, I talk about the in the past when patients never came to you first, you never had to determine whether or not there was an ongoing, life-threatening maybe, medical problem because they didn't get to you until after they were screened by medicine. Now they come to you first. So it's critical you do examinations, not just to find out whether or not they have issues you can treat, but to make sure that they don't have an issue you can't treat.
So as the non-clinician, I'm going to go down this road of looking at it from a claims perspective, because I can tell you that oftentimes I'm looking at a case. Typically, it's motor vehicle workers' comp because there's more hands-on there than the automated electronic functions of health insurance claims. But there's a patient, they get their exam, they get their list of diagnoses, they get treatment, and I see all this on the claim, right? And then as time goes on, I'm watching the diagnosis stay exactly the same, but I'm watching the treatment codes change. And then all of a sudden, one day, they're discharged.
With no change.
With no changes in diagnoses. They're still getting a whackload of supportive procedures right up to the last day. And I never really see a re-exam, or if I do, it's very sporadic. It doesn't seem to have any particular, sort of routine as to when they're being done. And I'm saying to myself, if I was paying this bill, I would have some questions.
You nailed it right there. So when we talk about managing expectations, well, first of all, you have to have an expectation. So the examination is what is necessary to define essentially where they start. This is the beginning. This is what I now know about this person. This is what works. This is what doesn't work. So my expectation would be to hopefully change that. So once we do the exam, we do the history, we do the physical exam portion of that E&M visit, that evaluation and management visit, come up with a diagnosis. And that's what you're talking about, right? The diagnosis for that day. And based on all of that, you come up with a plan of care that you will execute for a certain period of time with certain expectations. And it's those expectations that need to be monitored.
I want to take a moment to break down a little bit relative to the exam itself and talk about some of the challenges that I see relative to the exam. I'm gonna center in first on the assessment or the diagnoses portion, because doctors, there's seems to be a lot of times a very generic listing of diagnoses. And what I'm really talking about here is pain codes, cervicalgia, thoracic pain, lumbago. And I'm saying to myself, you've got a pretty good exam. You've got a lot of history. You've got some outside data clinically. I dare say that you could probably, with some assurance, know where that pain's coming from and perhaps list the diagnoses you're treating that's beyond just the symptom.
You just went down the path that ICD went down. They took all the ICD-9 codes that were mostly symptom-based codes, only about 15,000 of them, and then they created ICD-10. They went up to 70,000 and basically said that a symptom code should not be used unless there is absolutely nothing else or you have a pending test before you can determine what the diagnosis truly is. But other than that, they want to know the condition. They want to know what's wrong with that person. And you can't do that without doing some level of discernment, if you don't want to use the word examination, some level of discernment. And doctors, I'm going to put to bed this whole concept that chiropractors don't diagnose. You're wrong. A subluxation is a diagnosis. It is not a finding. Subluxation comes from an amalgam of many findings. And you, as a chiropractor, in fact, you're the only one as a chiropractor that can conclude subluxation. And this is well-founded in the whole Medicare model. It's what we do. Subluxations are not an objective finding. Subluxation is a diagnosis.
Well, I'm glad you put that to bed because I can't understand why they could ever submit a claim if they've never diagnosed a patient.
Oh, I know. What?
Box 21 clearly says diagnoses.
Mm-hmm. And what do they put in Box 21?
ICD-10s.
Right. The M99 codes, which are, Medicare calls a subluxation. Even though the definition says segmental dysfunction, Medicare recognizes it as the chiropractic subluxation.
Your claim form even puts down what version of ICD they're using, which now is 10, clearly.
So if you think subluxation is a finding out there, please stop that. Subluxation is a diagnosis.
Or stop submitting any claim whatsoever, ever.
Right. Yeah. If you say you don't diagnose, you're wrong because the fact that you don't have something else is diagnosing that it's not that.
Now let's go. This happens less often, but I want to go to the other extreme on diagnosing. That the doctor will put the kitchen sink in there, even what they're not treating. Oh, the patient may have that condition.
Yeah. But hair loss, they have thinning hair, turning gray.
They're not, it's kind of like you're the classic examples, right? You're not treating the fracture, you're treating the conditions as a result of the fracture. You're not treating multiple sclerosis, but maybe conditions that are affected by that diagnosis. Or you're doubling up on this pain issue where you're using an acute ICD-10, like a sprain code, or, I don't know, you tell me, sciatica code, right? Now, those beg sort of that there's pain somewhere.
ICD-10 assumes pain.
It's in the descriptions.
It's in the descriptions of each of the codes. And it's necessary to diagnose accurately and completely because it really is the validation for your care. But also, what you had mentioned earlier, it becomes the reason why you proving that you're getting better. Diagnoses are supposed to improve.
Yeah. And so my pet peeve is this excludes one issue that comes up because now the clearinghouse is kicking back the claim because you put cervicalgia and you put sprain of the neck in the diagnoses, and it's a bit redundant. Someone sprains their neck, correct me if I'm wrong, they might have some pain.
They might have some pain.
Right?
And you think by just piling on all these diagnoses, you're going to get paid more. And actually, you've probably hurt your chances of getting paid more.
You've certainly aggravated your billing people. So
that's for sure.
Stop that.
Yeah. So stop aggravating Paul, please.
Yeah, exactly. So, and one of the other portions I want to talk about relative to exams and re-exams specifically is about when you're doing these objective findings and you go back to the previous exam and you're like, wait a minute, now the doctor did these objective findings that there was nothing new to lead him to this, and they ignored positives from the last.
Oh, I love re-exams that have a whole different set of findings, procedures than the initial exam. It's very simple. You do your initial exam. I get the question all the time, well, what's a good exam? I said, everything necessary to determine
Yeah,
whether
but
or
I want to
not
know exactly.
I want to know. Tell me the 6 tests I need to do so
Yeah.
that I'm covered. I said, no, you do what you need to do to determine whether or not that patient should or should not be in your office and whether or not chiropractic care is going to help or not help them. Once you've determined that, you have an exam. Some things will show a finding. Some things will not show a finding. Please repeat all those things that showed a finding before that were, quote, positive later on when you do your re-exams, because that's how you document that what you're doing helps, along with all the metrics attached to those findings. You might start out with a severe finding, and hopefully by the re-exam, it goes down to a moderate or a mild finding. But essentially, you have to show improvement. But remember, you're asking someone else to pay for this, whether it be the patient themselves or an insurance company. They want to know that what you're doing is working and that it would be better for them to cover it or pay for it than not to.
And it would be really helpful when you are doing all of that and a patient is resolving, because patients can resolve some of their issues, right?
At least the reasons why they think they're there.
Right. So if they're no longer hurting or they're no longer in a sprain, it's resolved, feel free to drop that off the claim.
Oh, please.
Be helpful.
And feel free to tell the patient, this is also about managing their expectations, because they want to be shown they don't want to just feel better. They want to be shown that they're better. All those things that were not, say up to par. Maybe my posture looked really bad when I started as a patient, and somewhere along the line, I've shown improvements in my posture. Well, it's up to you to demonstrate that to the patient. It's not their responsibility to reproduce Sperlings on themselves to make sure that it doesn't hurt, when they do that particular test. So it's good patient management to take a patient and move them along and show them the pain diagrams that had all these X's and O's all over the place, covered the whole body. And now all of a sudden on the re-exam, there's just way less of them, or, gone for the most part. Or their outcome assessment tool was a 68 and now it's down to a 42 or whatever. These are things that are not just demonstrating to the people who are paying for the care, whether it be the patient or the insurance company, but it's also demonstrating that what you do works, which we need out there. We need everybody to know that what we do works.
I got a lot more to say here, but let's break it down. We got to talk about treatment plans, because let's help demystify what should be in a treatment plan. Meaning, doctor, should the treatment plan be just what you're going to be doing that day, or could it include things that you think might become relevant over that 4 to 6 weeks, let's say, before the next?
Yeah, when we break down the components of an exam, the history, examination, the diagnosis, and then the plan of care. Well, the plan of care is your best guess at that moment in time. So that's where you put in the laundry list of stuff that you might do. I am going to adjust. I am going to prescribe therapeutic exercise. I might do some ultrasounds. I might do shock wave or decompression, or whatever it is that you think you might do. And whether or not you do it will be part of the daily note, which is the SOAP. And that will be based on your findings for the day. But when it comes to an exam, you're kind of saying, this is my expectation. I am going to treat you. I am going to do these things. I'm going to do them over a period of time. I have certain short-term goals. I have certain long-term goals. These are my expectations. So when we talk about managing the expectations, well, you first have to state what your expectations are.
Right.
And that's what the plan of care section is when it comes to an E&M.
So let's refine that statement by me asking you this question.
You say that wasn't a refined answer?
It was, but I might take away from that because I'm looking for the path of least resistance and say, oh, so I'll just list a bunch of CPT codes, or I'll just list a bunch of services without clinical rationale or expectations of goals.
Everything has to link back to the findings. So the S, the history, why they're there. The examination portion is examining the reasons why they're there. The diagnosis is defining the reasons why they're there. And then the plan of care section is telling what you're going to do about the reasons why they're there. So you don't just throw everything in. It has to be specific, and it has to relate back to your plan of care has to relate back to the other 3 sections. So again, here's another revelation, doctor. This is the most important visit. The initial exam is the most important visit that you can complete accurately if you plan on treating this person more than twice.
You're building a foundation for medical necessity right from the start.
Right. And if you don't like those words because you're a chiropractor, sorry. It's the world we live in today. That's the world we live in today. Everything is based upon medical necessity and their definitions of medical necessity, not yours. Plan of care doesn't mean you just plan to care. You actually have to have all the reasons why you're going to do what you do and how you're going to do it and how much of it you're going to do. And there has to be a rationale that's consistent with the people that you're asking to pay for it. So we know Medicare's definition of medical necessity might be different than Blue Cross Blue Shield's definition of medical necessity. And both of them are probably different than your definition of medical necessity.
Well, it brings me to all the way back up to the S part, which is I think that it can be a very overlooked portion of the exam, which is the patient, family, and social history. One, some doctors just don't even do it, which on the initial exam you should be. But 2, built into that could possibly be some factors that might complicate recovery, therefore continue to justify either the treatment frequency or duration.
Absolutely. We have such things as genetic disorders that may or may not be passed on, that may or may not affect what we do and how much we do or the expectations of what we do. We have congenital factors that are not necessarily passed on, but sometimes they may come into play, that there's a preponderance of certain things that might happen or repeat. Family histories are very important. Social histories, your habits, all of that stuff that's part of the history section of your E&M is critical in laying what you just said, the foundation for what we do and why we do it. If you plan on adjusting that person once or twice or 3 times, yeah, maybe that stuff isn't quite as critical as one might expect. But if you really expect to get to have these people treat over multiple visits over an extended period of time and have someone else help pay for it, it's critical.
Well, and one of the areas that sometimes I see docs trying to avoid the history is previous accidents, where it's like, well, why would you hide that? That may create this whole
you mean because the attorney said don't talk about the past accidents. And here we go with other things that we said, but it's essentially what? The F word.
Yeah. To me, doesn't it play into the fact that they might have that eggshell syndrome a little bit, where the areas of complaint might be similar to a previous causality, but now they're just more sensitive in that area.
Yeah.
Right?
If you've had one accident, you certainly have injury, and you certainly have some level of permanency from that injury, because we never heal 100%, ever. So having it recur a second time, sure. Now all of a sudden we have to add that into the mix, whether the lawyer tells you to or not.
Well, and I don't know, I'd love to know the statistic, but there does seem to be a target on people's backs that they get into an accident and then like a couple months later, it happened again, So,
well, for some people, it's just a good living.
Well, I'm not going to go there, but that probably is true too. So let's get to the heart of the matter. We talked about exams, but should the doctor be doing these re-exams? What other than maybe trying to generate another service code for reimbursement, why would a doctor bother to do a full E&M service along the way?
Well, I mean, full is probably the operative word, because imagine a person comes in, they have an initial exam, you do the highest level exam that's necessary, and of course, according to the criteria. So let's assume you did a 99203 exam, which is very common for chiropractors, right? That's kind of the place they live at with an exam. And you do all these things, some of which are negative, some of which are positives. So maybe the re-exam might be a 99212, a lower level exam, because really all you're doing is just checking the positives. You don't have to redo everything unless it's something you think is significant. Again, clinical judgment. There's no recipe here. And everybody looks for the recipe when it comes to exams. There's no recipe. This is why becoming a chiropractor took 4 years and not 1. We didn't just learn how to adjust. We learned all the reasons why we should and should not adjust. And that's what the exam is all about. So when it comes to re-exams, you're checking progress and then restating a new plan of care based upon response to the previous care and whether or not it met your expectations, and then setting a whole new set of expectations. Keep using that word 1,000 times. That's really what we're talking about. E&M really should be expectations in management, not evaluation in management.
Oh, there it is.
Yeah.
Well,
I'm going to rewrite CPT.
Yeah,
I'm
right.
done. All right, I'm going to make a note here. Rewrite CPT.
Yeah.
Okay.
Boy, I wish I could.
Yes.
So I'm going to say, doctors, I think you should build it into your schedule. I know you're going to want to adjust 5,000 people and get as fast as possible, right? But if you build in this time for this re-exam with your patients, it's showing, one, that this actually is a different service than the adjustment. This is actually an official re-exam. 2, you're justifying your care not just to yourself and your patient, but also to a third party perhaps that might be reimbursing you for this. But also, you're going to give yourself the opportunity in that time period to talk about that patient specifically with that patient, as opposed to just blowing through the day. There's an opportunity to show that the care hopefully is working, and you have that opportunity to check in with that patient beyond the typical visit.
It's just good patient management. And believe it or not, I get pushback from chiropractors a lot on the concept of doing an exam or an E&M procedure on a certain day and nothing else. Well, they expect to be adjusted. Manage expectations. You're not going to be. It's that simple. It's an exam day. And the exam day is important in order to refocus that person on, if it's an initial one, what's wrong with them and what you're going to do about it. And then also later on to refocus them on what you've accomplished and what you hope to further accomplish. So the E&M is such a downplayed concept that chiropractors can't even wrap their head around the concept of performing an E&M without an adjustment on the same day. And it's like, it's too much. It's sensory overload. And so the one thing the patient will dump is everything you said about the E&M, and they'll go for the adjustment. Because especially if it's an initial visit, my God, that's to some people, that can be a very dramatic thing to be adjusted for the first time.
And concurrent to that, I'm a strong believer that you should be getting paid for what you do. So you should get paid. You should charge for your re-exams when you're doing them. And if it's not a covered service and your contract allows you to, you should collect from the patient.
You put in the plan of care re-exams. And when you talk about plans of care, just as an aside, always talk in terms of ranges, because there are no absolutes, right? So I am going to treat you, 2 to 3 times a week. I am going to perform a re-exam somewhere between 8 and 12 weeks. It's always about the individual. There is no recipe for chiropractic. It's what everybody tries to create, but there is no recipe for chiropractic. It's what's gotten us in trouble with insurance companies, because they believe that we don't discern anything, that we do the same thing to everybody and for all the same reasons, no matter what we write down. So please make sure that this is a very important thing to do your initial exam, do a good one. And from that good initial exam comes a good report of findings. And then later on, you do a re-exam and then a refocus to the patient. And this is how you manage your expectations with them and their expectations with you.
Yeah, but Doc, I do progress checks, so why bother?
Oh, boy. See where he snuck in that Medicare term? Because believe it or not, as much as we have just emphasized the standard of care of doing exams with re-exams, Medicare doesn't even actually advocate re-exams. What they do is require initial evaluations to determine the presence of subluxation, and then later on, only progress evals, which is simply an update of the outcome assessment tools and an update of the plan of care. Because their belief is that you perform enough procedures every day to validate everything performed for that day. So generally speaking, Medicare expects a more robust, to use your word a lot, right? A more robust daily procedure and daily note in order to justify ongoing care. Because that day, your note has to be complete enough to justify everything for that day. But the standard of care, basically, the general standard of care for an acute condition is that you should notice or see or observe a significant improvement in 2 weeks. And the reason why the patient came into the office doesn't mean they're better, a significant improvement. If there's no change, then you change your approach and you give it another 2 weeks. If there's no change after 4 weeks, based on your re-exam, then basically this patient may not be responding to your care, or you have to have a reason to continue. But as long as the patient is showing progress through the re-evals or the re-exams, then you have a medical necessity to continue treatment.
And I would say, as much as you have to comply with your contracts and Medicare rules and regs, don't let the system change you, doctor, from being a doctor, right? I mean, you have to comply with what you agree to, or whether it's by contract or a patient who's Medicare, whatever. But at the end of the day, your best practices, your standard of care, your peers who created and refined your rules and regs in your state from the chiropractic board perspective, all of these things play in. Don't let the world beat you down into this pulp of I'll just do whatever. I'll just skate by because, this says this.
Because I can.
Oh, gosh.
Remember, you're a doctor. You're not a technician. Because sometimes it's easy to teach somebody how to do a certain procedure. That's a technician. But why, how, when, where, what? All of that is what makes you a doctor. And when you start giving that up and you become just a technician, just an adjusting machine. Not that
that's coming. That's coming. AI, that's coming.
Please. That's a whole other thing. So, all right.
Anyway, so I'll end with a quote.
Okay.
To be yourself in a world that is constantly trying to make you something else is the greatest accomplishment. So, docs, be yourself, comply with what you have to comply with, but don't reduce your standards because you're trying to either save time or save the patient money.
Right. And remember, you are doctors, and I'll end with this other quote. No one can make you feel inferior without your consent. So you are doctors. And don't
You're staring right at me when you said that, too. What's up with that?
Don't let anybody else convince you otherwise that you are not a doctor.
Boy, is that true. Yeah. All right. Well, thank you again for listening to another episode of All Things Chiropractic. I'm Paul Andrews.
And Dr. Mark Davini. Thank you, Paul.
Thanks for listening to All Things Chiropractic. We'd love to hear from you. Visit allthingschiropractic.com with comments, episode ideas, or questions. Or connect with us on Facebook and Instagram at All Things Chiropractic Podcast. Be sure to join Dr. Mark Davini and Paul Andrews next time for another episode of All Things Chiropractic.